Good evening, ladies and gentlemen, and good morning from Dallas, Texas. The challenges of spine surgery in osteoporosis can be of three different types. The first one is the osteoporotic vertebral compression fracture. And this can lead to deformity as well as neurological damage, poses another challenge. And everyday surgery for spine, when it is done in presence of osteoporosis in elderly, then it becomes challenging. Let us deal with it one after the other and come out with a clear message for all of these three factors. The first and foremost is the osteoporotic vertebral compression fracture. This has been recognized for many years, and people in the past have tried to do mini open vertebroplasty, which used to be done infrequently and is very rare these days. But percutaneous vertebroplasty, by putting a needle into the lesion in the vertebral body and injecting cement into it, was first reported in 1984 in a small city in France by Mathis and Balkov and Deraman. Following this report, multiple reports were there for injecting cement into vertebral body lesion, and at some point during 1980s, people started injecting cement into acute painful osteoporotic vertebral compression fracture with pleasant surprise that the pain resolves almost immediately. And this has led to a very widespread use of vertebroplasty. People started recognizing the side effect or the complications like adjacent vertebral compression fracture, or more importantly, cement leakage into vein that can go to lung or into spinal canal and leading to paralysis. To prevent that effect of cement leakage, kyphoplasty was originated, where you inflate a balloon into the collapsed vertebra to make up some room and fill in that void with cement, minimizing the chance of cement leakage. As an added benefit, you can possibly restore the vertebral height to some extent by using the balloon, and that coins the name of kyphoplasty. There is no good proof or good study establishing that kyphoplasty can restore the vertebral body height, although in some cases it can do, as you can see in this example. The real challenge of vertebroplasty or kyphoplasty is the cement leakage. When it leaks into bone, into veins, it can go into lung, like in this patient, one of mine, where a lot of cement leaked into the pulmonary artery, and few weeks later we lost the patient. This is a life-threatening complication. But more frequently, cement can leak into spinal canal, and if it is large enough, may cause paralysis. Cement leakage along the nerve roots can cause intractable radicular pain. The leakage usually happens through the central vein of the vertebral body. There are several techniques one can do to prevent excessive cement leakage. If you're using a piston and syringe filled with cement like this, you can dip it in warm water to make it a quick setting for the initial injection of cement to prevent cement leakage. The other techniques are point the nozzle towards the end plate, which is not fractured and less chance of cement leakage. If you find tiny amount of leakage, you stop injecting any further cement and let that small amount of cement to solidify, and then keep on injecting behind that cement, minimizing further cement leakage. Or you can work on the other side if you find cement leakage from one side. There are other techniques, like if the nozzle for injecting cement is flexible, then you can bend it away from the area of cement leakage and continue further cement injection. Whatever you do, you have to be very careful to prevent any cement leakage. You can do using only one C-arm, but the cement leakage may not be visible in one plane, and to prevent that complication, it is preferable to use two C-arms simultaneously. We first position one C-arm in the lateral position and drape over it, and then bring another C-arm on top of it to perform vertebroplasty so that every drop of cement that is injected is immediately checked with both AP and lateral plane. In August of 2009, after the vertebroplasty has exploded to a very large number of people doing it in large quantity and people realizing the complications, there were two articles were published in New England Journal of Medicine. And both these articles concluded that we found no beneficial effect of vertebroplasty as compared to sham procedure or compared to non-operative treatment. And this took the surgeon community by surprise because most common experience is that vertebroplasty take care of pain almost immediately after injection. Whether the pain relief is due to additional support of the trabeculae with cement or killing the nerve endings or pain fibers in the trabeculae, it is not clear, but it is very clear that the pain relief is almost immediate. And this debate went on more and more, and more recent articles establishes that beyond doubt, vertebroplasty is successful to relieve pain in acute osteoporotic painful vertebral compression fracture. The take-home message is that while it is very effective, it is potentially dangerous. Use two C-arms simultaneously, watch for cement leakage and stop before it leaks more, and do no more than 3 vertebrae at one session to prevent excessive cement leakage into pulmonary arteries. The next challenge in presence of osteoporotic fracture when it leads to deformity or kyphosis with or without neurological damage. This is reasonably common in this unfortunate young lady of 45 who had seizure disorder and was being treated for a long time with phenytoin and carbamazepine, very notorious for producing osteopenia, and she continued to develop progressive kyphotic deformity. And finally, we had to do something, and we operated with a pedicle subtraction and very easy correction of deformity because the bones are soft. But the correction did not last long. Within few months, the distal fixation failed, and we tried desperately to reinforce the fixation, but with failure. This kind of experience is reasonably common in the 79-year-old lady who originally had osteoporotic vertebral compression fracture treated successfully with kyphoplasty, but later on developed kyphotic deformity with spinal stenosis, and that was treated by a small laminectomy, and that led to further collapse of the spine because the posterior element or the lamina are relatively unaffected part of the spine giving stability, and the moment you remove the lamina in presence of anterior vertebral collapse, the entire spine collapses, leading to both mechanical instability and neurological damage. And this lady developed not only paralysis but bladder and bowel incontinence. So we had to do surgery. We did reasonably extensive surgery, and the proximal end we used hook and caudally directed screw combination. Distally we went to pelvis, and she had a reasonably good pain relief and resolution of neurologic deficit and successful ambulation for few more years. This is not an isolated experience. In this lady with Parkinsonism, little older, osteoporosis, had osteoporotic vertebral compression fracture, but later on developed kyphosis with neurological deficit and cord compression. We corrected it with a combination of long segment fixation, cemented screw at the caudal end, caudally directed screw at the cranial end, and also another device called sublaminar tapes. These sublaminar tapes are much more resistant to cutout of the lamina compared to sublaminar stainless steel wires, and we had a reasonably successful outcome, and the patient was happy, regained neurological status, and be ambulatory and pain-free. This is another example where we have used cement-augmented screw caudally and cranially in addition to sublaminar tapes. This kind of successful story are not uncommon, like in this lady, 79, regained her ambulatory capability, but 3 years later, from cardiac complication not relevant to kyphoplasty, she died, and we received a letter from her son who said, "Thank you very much for giving us years of her thin surgery. Mom rarely had any pain, and she had a much better lifestyle than she had years prior to kyphoplasty." We had similar experience published from Mumbai by Dr. Uday Pawar and Dr. Abhay Nene and his team, and they have suggested different kind of surgical intervention to supplement laminectomy. But the take-home message is that never do laminectomy alone in osteoporosis. And the last challenge is regular spine surgery in osteoporotic bone. This is not uncommon. Like in this patient, restored sagittal balance with pedicle subtraction osteotomy, in no time developed proximal junctional kyphosis with screw cutting out of bone that was repaired with further cranial extension of fixation with some kyphoplasty in the adjoining vertebra. But still that fixation failed and patient went into proximal junctional kyphosis. This is a frequent problem. In this unfortunate lady who was 68 with osteoporosis, went to a world famous surgeon, very famous for doing disc replacement, and he treated degenerative back pain with disc replacement in front and flexible device at the back, causing 360 stabilization. But because bone was osteoporotic, started developing compression fracture, which collapsed further, and surgeon was not intimidated, but did a corpectomy, used a Moss cage in front of the vertebra for replacement of the vertebral body, which is notorious to cut into the bone, and in addition did a flexible device or Coflex at the back, interspinous device, and extended the fixation cranially. But that did not stop her misery. She developed further proximal junctional kyphosis as well as kyphotic deformity distally with pain throughout the back. We had to do surgery on her, and after exposing, we found that the cranial end developed an acute kyphotic deformity, and caudal end had the interspinous device and also a flexible spring kind of a device at the caudal end. We removed all of these devices and connected with a long construct, and essentially we did at the cranial end a caudally directed screw and hook combination, and this combination actually provided a lasting relief, and she was very happy even at 6 years post of follow-up. However, not always we get good outcome with caudally directed screw and hook combination, and it can fail. Like in this lady, further cranial to the fixation developed osteoporotic vertebral compression fracture, failed with kyphoplasty, and we had to extend it further higher up with caudally directed screw and hook combination again. Other option is to do cement augmented screw, which can be done simply by doing a vertebroplasty before putting screws, or you can use a fenestrated screw, either fenestrated towards the tip or towards the middle of the shaft to give some rigidity of fixation. And in this case, where the hook and screws both failed with subsequent osteoporotic fracture, we revised it with cement augmented screw. Another example of cement augmentation is that we used both cranially and caudally cement augmented screw in combination with the sublaminar tape with successful outcome in this elderly lady. In degenerative back pain coupled with sacral osteoporotic fracture, when we had to do surgery, we used cement augmented fixation, including pelvic fixation, with reasonably good outcome. However, Regardless of cement augmentation or caudally directed screw or sublaminar tape or hooks, none of these would survive unless you treat the osteoporosis promptly, both before surgery and after surgery. Prepare the patient with medicine before surgery, and we use teriparatide, which is a reasonably quick-acting medicine. This is similar to parathormone, which is 84 amino acid polypeptide, and the first 34 amino acids in the amino end is the active ingredient of this polypeptide that can be synthesized in laboratory, and that makes teriparatide or terifran. They combine with precursor of osteoprogenitor cell to differentiate into osteoblast, causing quick laydown of bone. And in our practice, if we treat the patients prior to surgery for at least a month, preferably 2 months, that gives a bone quality that you can afford to do surgery without risking further failure. The other uses of teriparatide is to enhance fusion and also enhance fracture healing besides treatment of osteoporosis. Another similar drug besides bisphosphonate, which is age-old drug being used for treatment of osteoporosis, is denosumab, which acts differently. While bisphosphonate adheres to bone and stops osteoclast to resorb bone, but denosumab actually kills the osteoclast and blocks the formation of osteoclast. And it is much faster acting drug with a rapid onset of action and shorter half-life compared to bisphosphonate, making it more effective not only in the treatment of osteoporosis but also in the treatment of giant cell tumor and similar other bony lesions. To summarize, surgery in osteoporosis is challenging. For osteoporotic compression fracture, remember kyphoplasty is potentially dangerous and watch for cement leakage. Kyphosis and stenosis in osteoporosis is common, but do not do standalone laminectomy. And most importantly, while performing surgery in osteoporotic bone, do not forget to treat osteoporosis with medicine before and after surgery. Thank you very much for patient hearing.